Today we'll be discussing the incretins, their physiology, how they work, and how it has shaped the management of diabetes. First, we'll move on to the history of incretins. This term was coined by a Belgian physiologist, Labarre, in 1932. It is a blend of this word, no, incretin is a blend of the words intestine and secretion. So if you can see here, incretin is nothing but intestine plus secretion. So it is any gut hormone under physiological conditions stimulates or contributes to pancreatic hormone secretion. It means, so when a food is taken orally, what happens is the food will stimulate the release of some gut hormones that will go and stimulate your pancreas to release more and more insulin. So any gut hormone which increases the pancreatic secretion, we call it as incretins. So it is an intestinal hormone which improves the secretion in the from the pancreas, and that is your incretins. So these are gut derived hormones that regulate blood glucose level by amplifying insulin secretion after eating. You have to be very clear here. After oral intake only this effect is seen. So this effect we call it as incretin effect. It means there is a greater insulin response to oral glucose when compared to IV glucose. See here in this graph you can see this red color line indicates it's the level of insulin when IV glucose was given. The blue color line indicates the amount of insulin secretion after oral intake of glucose. So what you can see here is the blue graph is higher, right? So the amount of insulin released at the end of 1 hour after oral glucose intake is very high compared to IV glucose. So what it tells is when you take the glucose via IV line, the amount of insulin released is less. But when you take the same amount of glucose orally, the amount of insulin secreted is very high. It tells that there is something in the intestine or gut which is stimulating your pancreas to produce more and more insulin. And this effect is called as incretin effect. Okay. So now coming on to the types of incretins, there are two hormones. Okay, one is GIP, the other one is GLP-1. GIP is produced by K cells, which is present in duodenum and jejunum, and GLP-1 is secreted by the L cells present in the distal intestine. So just remember, in the early part of intestine, we have K cells, and that produces GIP. And L, you remember GLP-1, the it is secreted by L cells, and that is released from the distal intestine. So as you can understand here, these are mainly released from intestine. That is why we call it as incretins. In stands for intestine here. So GIP and GLP stands for glucose dependent insulinotropic polypeptide. So GIP is nothing but glucose dependent insulinotropic polypeptide. It means in the presence of glucose, insulin production is increased by this polypeptide. So that is the meaning of glucose dependent insulinotropic polypeptide. It is also called as gastric inhibitory peptide. GLP-1 stands for glucagon-like peptide, mainly GLP-1. So here glucagon-like peptide meaning, remember it structure-wise it is similar to glucagon, but this hormone GLP-1 actually increases the production of insulin. So what are the functions of these incretins? From the first slide, I've been repeating like it stimulates the insulin release. So it's a glucose dependent insulinotropic action. So it releases more and more insulin in the presence of glucose. At the same time, it suppresses glucagon secretion, especially glucagon like peptide 1. It also delays gastric emptying. And remember, your GLP-1 directly acts on the brain and it promotes satiety and appetite regulation. So it helps in food intake also. And it also contributes to lipid metabolism, especially the GIP hormone. Gastric inhibitory peptide has a major effect on lipid metabolism. So just to summarize till now what we studied, there are two incretins, okay, GLP-1 and GIP. GLP-1 is released from L cells from the distal gut. It increases insulin secretion, reduces glucagon secretion, and it also reduces the gastric emptying. So its main role is it controls the glucose level or regulates the glucose level, at the same time also provides satiety. So therapeutically this GLP-1 agonists are used in diabetic patients and obese patients. GIP is released by the K cells from the duodenum and jejunum. It also increases insulin, but it has major effect on fat metabolism. So main function is it helps in lipid metabolism and storage of fat. Therapeutics, remember there are no direct drugs available at for or agonists are available as for GIP. So clinically what is important, clinically effective incretin is GLP-1. So we'll slightly go into further details about GLP-1. Now, there is an enzyme called DPP4. Okay, this is again is released by the cells, and many in the circulation also this DPP4 is available. What we'll do is, we know GLP-1 is an incretin hormone secreted by the L cells after meals. Now, this enhances insulin release. GLP-1 releases insulin, suppresses glucagon, slows gastric emptying, and promotes satiety. Now, we have an enzyme which will break this GLP-1. So, DPP4 is an enzyme found in many cell surfaces and in circulation. And that's main role is to degrade this incretins, especially GLP-1. So, very simple here. GLP-1 is an incretin. DPP4 is an enzyme which breaks down GLP-1. Clear? Because of this, what happens is the naturally available GLP-1 has a very short half-life. Like maximum is around 1 to 2 minutes it will be present in the blood. Hope you guys are clear here. So we are talking about DPP4, which is an enzyme which degrades GLP-1. GLP-1 is a hormone which releases insulin. So in diabetes now, how they have used this information is that now GLP-1 receptor agonists are available. Okay, GLP-1 RAs we call it as GLP-1 receptor agonists. These are synthetically available molecules, but they are resistant to DPP4 degradation. Even though diabetic patient has DPP4, now this enzyme cannot break down a synthetically created GLP-1 receptor agonist. So what happens? The GLP-1 will have a longer duration of action. Also, DPP4 inhibitors are available. So that is nothing but your gliptins. I think you would have heard about sitagliptin and that class of drugs. They are DPP4 inhibitors, meaning block the enzyme. They block the DPP4 inhibitors block the DPP4. So what will happen? Endogenously, naturally produced GLP-1 and GIP will have a longer action. So it will have a longer incretin effect. So hope you guys are understanding here. If we move on to the previous slide, I told you DPP4 is an enzyme that breaks GLP-1. So now what they have found out, they have blocked this enzyme. So there are DPP4 inhibitors are available. At the same time, DPP4 can act only on a naturally or endogenously produced GLP-1. So now what scientists have done, they've created synthetically GLP-1, which is resistant to DPP4, meaning DPP4 cannot destroy a synthetically produced GLP-1. So we have two different class of drugs available to treat diabetic patients now. One is DPP4 inhibitors, so that it cannot break a naturally produced GLP-1. At the same time, a synthetic GLP-1 is also being produced. Now, that's what has been told, summarized here. DPP4 normally breaks down GLP-1. GLP-1 drugs bypass this degradation, meaning the synthetically available GLP-1 receptor agonist drugs. No, DPP4 cannot break that. At the same time, DPP4 inhibitor drugs protect the natural GLP-1 from degradation. So now, we'll just compare these two class of drugs now. GLP-1 receptor agonist versus DPP4 inhibitors. What is the efficacy, safety, and for where is these drugs used? So two main things what we have been talking is, one is glycemic control, the other one is weight loss. Okay, so GLP-1 receptor agonists, no, they are better in terms of glycemic efficacy and weight effects. So just see here, GLP-1 receptor agonists, they provide greater HbA1c reduction. Fasting and postprandial glucose reduction is also better in with the GLP-1 receptor agonist when compared to DPP-4 inhibitors. And also remember, GLP-1 receptor agonists, no, they promote significant weight loss, and DPP-4 inhibitors, they don't have much effect on weight. So imagine there is a diabetic patient who is obese. Okay, and he has a very high HbA1c level, fasting and postprandial glucose is highly disrupted, then it is better to give him GLP-1 receptor agonist. Okay, DPP-4 inhibitors are usually given for patients who are like weight or like usually within a normal weight range. If your main goal is to reduce somebody's weight, some patient's weight, then you better to give the GLP-1 receptor agonist. Now moving on to route of administration and tolerability, GLP receptor agonist, the major setback here is it is an injectable. It's available only as injections, sometimes once weekly, but the side effects is still almost the same side effects like nausea, vomiting would be there. It improves with a gradual dose titration. Okay, DPP-4 inhibitors are oral. This is the major advantage of DPP-4 inhibitors, but they have fewer GI effects. It can cause sometimes mild infections like nasopharyngitis. So here what is the take home message here is GLP-1 receptor agonists are available as injections only. DPP-4 inhibitors are available only as a oral form. So broader clinical outcome and use, if you see, GLP-1 receptor agonists also provide cardiovascular protection. So, if a diabetic patient also has a cardiovascular disease and he's obese and he has a fatty liver and he also has some amount of neuropathy, then better go for GLP-1 receptor agonist. DPP-4 inhibitors are mainly safer in older patients and CKD patients, and it is convenient. Oral dosing is enough. Also, it has a low hypoglycemic risk. Okay, when DPP-4 inhibitors are given. So, just to summarize here. GLP-1 receptor agonist has a better HbA1 reduction. It provides better HbA1c reduction. It also provides weight loss, but given as injections. Remember, very few side effects are there. Mainly used in type 2 diabetes mellitus patients, obese patients, and cardiovascular disease patients. But DPP-4 inhibitors main advantage it is orally available.